disease risk and the various factors related to that. So thank you, Professor Parekh, and over to you.
Thank you very much for inviting me. And this is actually my first webinar ever. So I look forward to answering questions at the end. What we're going to start with today, I actually changed my title a little bit. It's that the state of heightened CVD risk in dialysis patients. And I just want to let you know that I've got some funding from the Astellas. So what I'm going to primarily review today is what leads to increased cardiovascular disease risk in dialysis, the incidence of sudden cardiac death. I'm going to talk about arrhythmic risk, and I'm really going to try and focus on one potential modifiable risk factor that we manage in dialysis, calcium, and sort of show you whether we should really be thinking about that differently when it comes to sudden cardiac death. What's really been evident since the last 20 years in which we've known that cardiovascular disease is actually the most common cause of death among dialysis patients and those with chronic kidney disease is that we've really been thinking about cardiovascular mortality overall and trying to adjust for traditional risk factors and albuminuria. But what we found in dialysis patients is that the risk of mortality is about 10 to 20 times greater than the general population and almost 100 times greater than those who are young adults. The difficulty is that how we classify cardiovascular disease remains an issue, and as nephrologists, we may not think about it as just atherosclerotic disease. What's really complicated is that there's multiple issues with composite endpoints in cardiovascular disease studies. And when people look at MACE, or the major adverse cardiac events, and percutaneous coronary intervention, this is just a list of cardiovascular trials that have been going on, mostly in North America. And you can see that across the top, when it has composite name and death, cardiac death, MI, you can see these check boxes. And you can see that depending on the type of study, in fact, the definition of cardiovascular disease may vary quite greatly. So what do we know within cardiovascular disease trials in dialysis patients? Well, what we do know is that the number of trials that have actually had multiple types of outcomes include cardiac death. They also include non-fatal MI or cerebrovascular disease. Some of them, though, only include all-cause mortality, unstable angina, congestive heart failure, or peripheral vascular disease. So it makes it difficult for us to really compare the studies as we're not consistently looking at the type of outcome that perhaps is the biggest issue within dialysis patients. So what really leads to mortality in end-stage renal disease? Well, a study that we conducted in 2008 in the CHOICE cohort actually showed that sudden cardiac death was the most common single cause of cardiovascular disease. It accounts for 20% of mortality over 8 years. And overall, the mortality rates are quite high in dialysis patients at 80%. But out of that 80%, 20% are just related to sudden cardiac death. 27% are a mixture of other cardiovascular diseases, such as atherosclerotic disease, potentially surgical intervention for atherosclerotic interventions, carotid disease, cerebrovascular disease, peripheral vascular disease, congestive heart failure. And so it's really sudden cardiac death that's the leading cause. However, most of the studies have not focused on sudden cardiac death as the main outcome among dialysis patients. When you take a look at how you define sudden cardiac death, it's really that you need to be prepared to expect the unexpected. That in fact you will hear and often hear about dialysis patients dying at home, and that's really the sudden cardiac event that's occurred. So when we define sudden cardiac death in the different types of studies, there's registry data that is actually talked about taking a look at out-of-hospital death. This is your dead on arrival to an emergency room. You can have a cardiac arrest. Again, it's outside of the dialysis unit. What's important is that it's really the sudden unexpected death from a cardiac cause, that it occurs within an hour or 2 hours of symptoms, and then you're rushed to the emergency room, or you may die at home, or die as you arrive into the hospital. That this isn't the deaths that occur in the hospital or that are expected, but it's the unexpected deaths. What's complicated in dialysis patients, especially in North America, is that some of the patients are at home and have not been witnessed. And so the HEMO study actually had to classify sudden cardiac death as an unwitnessed death in the between dialysis sessions. So because of this, we really need to do a much better job about studying sudden cardiac death within the dialysis population. When you take a look at the incidence of sudden cardiac death, overall, it appears quite low in that it's on average about 40 per 1,000 patient years. But you can see that in the general population that the risk of sudden cardiac death is probably about 5 per 1,000 patient years. But the moment you have dialysis, that it increases quite substantially. It's pretty much the same whether you're on PD or hemodialysis. So even PD patients are at risk. Diabetics definitely have a much worse off than non-diabetics, but it isn't that different. And after an MI, again, it's much, much higher as expected. In the specific dialysis population that was studied that wasn't a registry, we were able to show that, in fact, depending on where you were and how you defined it, that the sudden cardiac death rates were actually quite different. But when you took a look at larger observational studies of the hemo trial, that in fact pretty consistently we're getting about 40 out of 1,000 patient years. And that's the number of patients at risk for sudden cardiac death. What's important again here is that this is just taking again look at different cardiac populations, including those who might have a GFR that's greater than 60, those who've got chronic kidney disease and not quite yet on dialysis. And so you can see that the sudden cardiac death rates actually increase quite substantially as you approach dialysis. But the actual counts are much, much higher in the general population, which is not unexpected because dialysis is still relatively rare. If you say, are there differences worldwide? Well, if you take a look at this, sudden cardiac death is actually listed in black, and you can see that the US has a much higher rate, but you can see that it really, other than the UK or other countries, that in fact it is persistently quite high throughout all the other countries. And what's interesting is that non-cardiac death may be higher in some other countries, and perhaps this is a classification issue. So what treatments prevent sudden cardiac death in dialysis patients? Well, we do know that beta blockers may have some benefit, and that when you take a look at those who have no ischemic disease and no beta blockers, those actually have the worst survival versus those who have the worst survival who have ischemic heart disease and beta blockers. If you got ischemic heart disease and no beta blockers, in fact, your risk of sudden cardiac death is a little bit higher. And if you've got no ischemic heart disease but on beta blockers, that there's still some difference in overall cardiac death. And you can see that if you took a beta blocker, you're about 10% less likely to have a sudden cardiac event, even after adjustment for multiple risk factors. And if you have pre-existing heart disease, in fact, you're 40% less likely to have a sudden cardiac event. What's important to note is that about 70% now of the US population are currently on beta blockers, and because of that, it's actually extremely hard now to discern if there's a difference because so many people are treated with beta blockers. What about prophylactic treatment with implantable cardioverter-defibrillator? So implanting an AICD, is that any benefit over time? So what's been interesting is that with the use of the ICD, you've actually noticed that there's a huge increase in secondary prevention. So those who actually fit MADIC criteria, who have congestive heart failure and advanced cardiomyopathy, that in fact the use there has become much more common, but also the use in primary prevention by cardiologists in placing the ICDs and thinking that patients are more at risk have actually also increased over time. However, if you get an ICD, that there's only a benefit within the first 2 years, however likely that there's no benefit over time between the two, whether you get an ICD or not. And what's actually quite remarkable is that the mortality rates are extremely high within the first few years after dialysis and after receiving the ICD, and there's definitely no benefit even as long as 10 years out. So the question comes up, how do you actually manage these patients, and how can we actually think about preventing disease? We did a similar analysis in those who had advanced chronic kidney disease in a non-dialysis population, and we're actually able to show quite similarly in those who had very advanced chronic kidney disease of a mean age about 69 in those who got an ICD versus a control population of about 75. And a lot of them were on a beta blocker. We matched them case for case, 180 cases with ICD matched to 180 cases without ICD in Ontario, Canada. And yet we were able to still see, despite all the risk factors that we matched for and age matching, that in fact there was still no difference even when they had chronic kidney disease. So the question comes up, is there really a benefit that you can see in receiving an ICD in those who got the ICD in the blue versus non-ICD in the black? So I think what we've been thinking about when I was at Hopkins was really what leads to sudden cardiac death and what's different in dialysis. And maybe we need to understand those mechanisms better before we can actually figure out a treatment in trying to prevent sudden cardiac events. So this is a schematic, which I'll walk through, that sort of highlights what are the critical pathways that lead to this electrical instability and sudden cardiac death. The most important thing to understand is that you need to have vulnerable myocardial substrate. And that really indicates that you have this myocardium that's at risk, and that any kind of trigger that can occur can lead to sudden cardiac death. And as you all know, atherosclerosis or coronary artery disease is actually one of the most common reasons in the general population that patients may have evidence of a vulnerable myocardial substrate, because atherosclerosis leads to fibrous scar and ischemia and leads to LV dilatation and myocardial stretch. We also know that you can have hypertrophy, and when you have hypertrophy, you can have stretching of the myocardium, and that leads to altered calcium regulation and fibrous scar, and LV dilatation and myocardial stretch also. So hypertrophy itself puts you at risk, scarring then puts you at risk, and then it can lead to altered repolarization. Again, what leads to hypertrophy and atherosclerosis? Older age, underlying hypertension, diabetes, smoking, obesity, and inflammation. What also happens is that you now have dialysis that is likely a significant trigger with sympathetic activation while on dialysis, electrolyte fluxes, and acute hemodynamic stress. And there's also likely a genetic predisposition too. Ultimately, you can then have the sudden cardiac event, and you may survive or not survive, depending on when your resuscitation occurred. So what we were interested in studying was, what are the arrhythmias that occur once you have this vulnerable substrate, and what are the potential triggers that may occur leading to sudden cardiac death? So the electrographic ECG metrics that are used in the general population are quite a number. Typically, the QRST angle, which I'll show you, or the QT-QTC interval, which is derived from a routine ECG. There are also special studies that can be done from signal average ECG monitoring of signal average ECG, T-wave alternans, or heart rate variability. Today, because of time, I'm not going to go into these, but just suffice it to say that, in fact, we haven't found an association in dialysis patients related to these parameters. We started this study, Predictors of Arrhythmic and Cardiovascular Risk in End-Stage Renal Disease, in Baltimore at Johns Hopkins. It was recruiting patients from over 26 dialysis units within the community. We were able to recruit them when they were incident to dialysis, and they were recruited within the first 6 months when they started dialysis. We brought them in for a specific cardiovascular evaluation, at which time we then measured a special ECG, and then determined the association with sudden cardiac death. And what we published a few years ago was taking a look at the electrophysiological substrate and the risk for mortality. What we looked at first was this QRST angle. And what's important is to understand that you actually take it from a routine ECG. And what you do is, when you take a look at this angle, you're actually taking a look at how you actually have the electrical impulse and how it migrates down through the LV and back. And then what is this angle overall that you have? So this angle that we have is the dispersion of the QT as it gets dispersed through the left ventricle, and it gets spread throughout, and how it actually causes then depolarization and repolarization of the myocardium. And this angle is basically the QRS vector compared to the T vector from an ECG. This wide QRS angle is associated with abnormal depolarization and repolarization, increased global electrical heterogeneity, and sudden cardiac death in the general population. So the wider this angle, the more that this QRS vector is actually dispersed in this direction, and this angle gets much bigger, really just shows how much heterogeneity there is in the electrical conduction, and that actually indicates a worsening arrhythmia. In one study of 277 patients on chronic dialysis with a mean age of 56 years and predominantly males, you can actually see that an angle of 130 degrees in men and 116 in women was associated with about 2 times greater risk of mortality, and also about 3 times greater risk of sudden cardiac death. And you can see that in this relatively smaller population, that in all-cause mortality, that there was definitely a difference between those who had abnormal QRST angle did much worse compared to those who had normal, and that it was also much more predictive for sudden cardiac death. This was a prevalent dialysis population who survived the first few years on dialysis. Remember, the mortality rates are highest within the first 2 years. What we found was very similarly, we also found that there was a risk when the angle was less than 75 degrees compared to those that were greater than 75, that in fact there was a high risk of all-cause mortality, a high risk of cardiovascular mortality, be it related to heart failure or atherosclerosis, but specifically at sudden cardiac death, that there also was a difference. When we took a look at per 10 degrees of your angle, you could actually see that there was a continuous association. For every 10 degrees, your risk went up by 5%. When we took a look at those who had angles greater than 75 degrees, you were about 2 times greater risk for cardiovascular mortality. But what was interesting was you were almost at 5 times greater risk for sudden cardiac death. So this showed us that there was really evidence that ECG metric was actually predictive of sudden cardiac death in this dialysis population from a routine ECG. What was important was we wanted to make sure we addressed all the different kinds of electrolytes that people are worried about on dialysis, all of the different volume changes that were on dialysis. And what was interesting was that it really did not change the association with the spatial QRST angle greater than 75 degrees, indicating that this angle is very important in predicting sudden cardiac death, independent of what we would think are electrical triggers that may occur because of fluctuations in dialysis. So what about the QT interval? Well, the QT interval, as you know, represents the duration from ventricular depolarization to repolarization, and it really tells us about the health of the myocardium itself. Its dynamic changes in the QT are usually related to the repolarization that occur, and it's very important that you can correct for heart rate. It's dynamic because of and highly variable because of electrolytes, medications, cardiac disease, autonomic tone, and sometimes your underlying genetics. It's been shown in very small studies of 68 patients on chronic chemo that don't have any evidence of heart disease, that prolonged QT is actually evident in 34% of patients, and that was related to serum. What was interesting was when they took a look at your pre-dialysis, that in fact there seemed to be a little bit of a difference in your post-dialysis when it was corrected, that it increased slightly. What was interesting was that it wasn't related to changes in potassium, but there was definitely differences when it was done at base rate, and then when it was done during dialysis and when there was follow-up. So there seemed to be some evidence of worsening QT after dialysis. However, the numbers are very, very small. In 122 patients on hemodialysis in this study, with a mean age of 71 and the duration of 3 years, again in this population, 36% had prolonged QT. And it was also, again, able to risk stratify and show that you were at greater risk for having cardiovascular overall mortality. And it was only a very small number of sudden cardiac events to be able to differentiate a difference in those patients of sudden cardiac death and prolonged QT. What was interesting was that when they took a look at overall mortality, that there was a higher risk of twofold, and there was an 8-fold greater risk with sudden cardiac death, adjusting for all of these different risk factors. So many patients on dialysis have prolonged QT intervals, and I'll show you that about 80% of PACE, depending on the definition. Hemodialysis session also affects the QT interval, although the factors that influence changes in QT are not clear. In small studies, prolonged QT interval is associated with increased risk of mortality, and what we wanted to understand was whether there was a risk for LVH. So what dialysis factors lead to sudden cardiac death in dialysis? What we were really interested in was whether there are dialysis parameters and electrolyte changes, in hemo especially, that potentially could portend poor prognosis in dialysis patients. In particular, we were interested in dialysate changes with serum calcium, with potassium, with magnesium, as well as with phosphorus. What we recognized, though, is that there are multiple ways that we measure calcium, and we wanted to get a better idea of which was associated, the total, corrected, or ionized. But we have to recognize that calcium, as much as we think about it from an arrhythmic risk, we also have to balance that we're in a total body load of calcium when we're on dialysis, and that we may be contributing to increased coronary calcification. We know that if we have a high dialysate calcium, that you're going to be at risk for vascular calcification, which leads to stiffness, increased blood pressure, LV hypertrophy, which ultimately can lead to worsening cardiac function, arrhythmias, as well as sudden cardiac death. If you have a low dialysate calcium, you're at risk for hypotension, prolonged QT interval, and ultimately again leading to cardiovascular disease, arrhythmia, and sudden cardiac death. So it's really balancing this fine tuning of the body in trying to maintain what is the optimal calcium that you need. So in PACE, in about 400 patients that were incident dialysis patients, we took a look at their average total calcium, which these are US measurements, not millimoles, so milligrams per deciliter. And we're able to show that the average was 8.7. When we corrected it, it was about 9.7. And we measured ionized calcium, which was normal on the non-dialysis days. In the DaVita units that we were using, we were predominantly using 2 or 2.5 calcium predominantly. And the serum to calcium gradient was about 2. And when it was corrected, it was about 2.2. When you took a look at our 12-lead ECG that we did through a GE Marquette machine, as well as 5-minute signal average ECG with a NORAV machine, we were able to show that, in fact, QT interval was incredibly prolonged. Just using raw data was greater than 440, which is abnormal in the majority of patients. When we corrected it using either Bayzet's formula or Hodges, we were able to still show that even adjusted for your rate, it was still prolonged. And what was interesting was 69% of patients that we measured in the 400 patients who came to the study visits had prolonged QT in between dialysis sessions. What was important to note was that at our baseline visit, we were able to show that many of them had even higher than the 65%, closer to 80% had evidence of prolonged QT if you use Bayzet's formula. And then in follow-up, you could see that it was still those who came, about half of them came back for visits, that it was still quite prevalent. So quite amazing that, in fact, QT interval is probably delayed in the majority of our patients. And not surprisingly, you could see that as your ionized calcium went up, whether you were male or female, you could actually see that your QT interval actually came down. And also if you had LVH or no LVH, that you were able to see that your QT interval came down. What's really important is among the electrophysiologists, they think that those that are greater than 500 milliseconds for QT corrected, be it Bayzet or Hodges formula, in fact was extremely abnormal. And it was extremely abnormal, especially in those who had LVH, but even some with no LVH. So what we showed was that longitudinally, and not surprisingly, total serum calcium was actually associated with a prolonged QT, in fact, increased it by 12 milliseconds. Your ionized increased it by about 9. And if you had higher potassium, it actually lower potassium, you actually increased it also by 12. And when you adjusted for multiple risk factors, you were able to show that it was still consistently associated with prolonged QT. So both calcium and potassium have definitely an adverse effect when they're low by increasing your QT interval. When we take a look at it over time, what we showed was that it didn't matter which calcium really, that they were all associated with prolonged, but ionized was much better, but this is much more complicated to measure in the dialysis unit. Potassium was also associated with prolonged QT over time. And when we adjusted for both calcium and potassium in the same model, we were able to show that total calcium was associated, but potassium was no longer associated with prolonged QT. The other thing that was really interesting was that many patients, probably about 40% of patients, were actually on some QT prolonging medication. And this is something that I don't think we really think about in dialysis patients, but some studies on patient quality and safety are actually identifying that perhaps we're not recognizing all the potential cardiac effects from all the medication that we give them. But on the balance, we have to recognize that we actually have to be able to treat patients appropriately by not necessarily increasing their coronary calcium. And the study done by Goodman et al. In 2000 actually showed that over time, in a young population, that in fact there's very little calcium when they're younger, probably because their bones act as a calcium sink. But the moment you become an adult, though, you start having much, much higher levels of calcium. And this is the Agatston score. And you can see that, in fact, this is a logarithmic scale with patients as high as 10,000 having evidence of coronary calcification. We also know that the longer you're on dialysis, the more that you're going to have calcification over time. And so this is really important for us to balance that there may be a balance of taking a look at the prolonged QT that we have to be concerned about in patients when they're first on dialysis, but maybe over time, we need to really consider what we do in terms of coronary calcification. So when we go back to these critical pathways, I think what I was trying to show is that even though we've done studies taking a look at atherosclerosis in the dialysis population, what we haven't really taken a look at is what happens when you've got atherosclerosis, hypertrophy, and arrhythmias, and you have this vulnerable substrate. What are the triggers that you have that ultimately lead to sudden cardiac death? And ultimately, what we really need to think about is how do we manage our patients when we're screening them when they first come to dialysis? Should we be screening them for heart disease, both atherosclerosis as well as heart failure? Should we be assessing for LVH, taking a look at fibrous scar, making sure that when we're managing them on dialysis that we're actually able to manage those fluctuations that occur, and trying to minimize the electrolyte changes that we can have on dialysis, as well as screening for arrhythmias, that now we actually have two metrics, both the prolonged QT interval potentially, as well as the QRST angle that we can take from a routine ECG and actually understand what the arrhythmic risk is. So in the United States and in Canada, before somebody goes to a dialysis unit, we often check an EKG, but never routinely check it while they're there on dialysis. And the question is whether we should really start thinking about more routine measurements of arrhythmias and thinking about how to manage them while they're there in the dialysis unit. So how can you manage patients now in order to prevent cardiac death? So really it's managing their underlying cardiac dysfunction. And do you know whether they have systolic or diastolic dysfunction? Have you got them on beta blockers? Have you been able to reduce their LV mass? Have you thought about more frequent dialysis? Have you thought about maximizing their volume as much as possible? We want to minimize these arrhythmic triggers also. And so again, trying to understand what we can do with potassium. Really what we know right now is just avoiding the very low potassium baths. However, it's not clear if the rapid changes from a high potassium of 7 to 2 may also increase those risks. We know that I think you should also avoid low calcium baths. And the question is whether you need to think about patients who are on concurrent use of QT interval prolonging medications that you might have on calcium mimetics because you're worried about high PTHs, that in fact you're trying to manage the calcium as much as possible. You also need to think about metabolic alkalosis, which I haven't shown here because we know that alkalosis can also make things worse. Rapid ultrafiltration potentially could make things worse, and so making sure that you're not taking off too much fluid. We also know that there's dialysis-induced myocardial stress that occurs, and so it's very important to try and reduce that intradialytic hypotension and that stress that may occur and precipitate sudden cardiac events. You want to take a look at the risks and benefits ICDs. I think while they're on dialysis, it's not clear that this is really what we should be doing at this time to improve survival. And what's very important and most recently shown by a study by Poon that just came out in the last few days in JASN, showing that in fact you need to make sure that your dialysis teams are actually ready and prepared to deal with cardiac arrest that may occur in the dialysis unit, as that definitely improves survival overall. So the incidence of sudden cardiac death is extremely high. It's about 20% of all deaths, especially in the first year on dialysis. The arrhythmogenic substrate is extremely common in hemodialysis and really well worth us thinking, how can we do this a little bit better in taking care of our patients? So I would propose that we should actually do more routine ECG screening, that we should actually think about risk stratifying, potentially using this global ECG metric so that we can start understanding who's at risk and potentially managing their dialysis differently. I think you can modify your dialysis prescription to achieve a higher calcium target, but recognize that we really do still have clinical equipoise on the use of beta blockers or on ICDs overall. I think in the future, because the ECG is inexpensive, readily available, the hope is that we can actually use the ECG more often within the dialysis unit. There might be multiple parameters that we could do. It's really difficult to get patients who come to hemodialysis to measure them more often in a non-dialysis setting. So the question is, when do you actually measure their ECG? Should you do it pre-dialysis, during the dialysis session, or after dialysis, or between dialysis sessions? What we also need to understand are what are the contributions of QT to mortality, but what we also don't understand are bradyarrhythmias that may lead to sudden cardiac death. In fact, there's some studies that are ongoing that are going to assess these implantable monitors that are very small that you can wear under the skin, that potentially we could assess what's going on with dialysis patients and determine if they're developing these bradyarrhythmias, in which time, if this is the cause of sudden cardiac death, we could actually potentially treat with pacemakers. And we also have to think about other ECG metrics to see if there's anything else that we could study that potentially could lead to sudden cardiac death. I think what's really important is that risk stratification, risk prevention are actually intertwined. So whatever factors will lead to sudden cardiac death can actually be effective therapy for us. And what's very important is that if you're thinking about ICDs, the placement in your dialysis patients, that you have to really think about what are the criteria that you're going to use before you treat them with that. And I think I actually finished a little bit early so that I could make sure that I had lots of time to answer lots of questions for people.
Thanks, Professor Parekh, for that presentation, which brings up really an important issue that often is not well appreciated amongst patients on dialysis here, at least in India and perhaps in some other countries, which is one of arrhythmia. And so I'm sure there are going to be quite a few questions. So you did provide a fair amount of insight on how to do risk stratification of patients on dialysis for arrhythmia. So let me just go straight on with the questions. And for the attendees, you know how to ask questions. You can either type your questions in the question pane, and I'll read them out to Dr. Parekh, or you could raise your hand. So let me read out the first question, which is from Dr. Sribhushan Raju from Hyderabad, and he wants to know, Dr. Parekh, that the data that you showed from the PACE study. So what was the timing of the ECG in that particular project? Was it done before starting dialysis, or after dialysis, or during dialysis?
It was actually done on a non-dialysis day. We brought them to the hospital, and we've specifically tried as much as we can to do them on a Monday or Tuesday, so that patients were Monday, Wednesday, Friday, they tended to get it on a Tuesday. And if it was a Tuesday, Thursday, Saturday, then they tended to get it on a Monday. So we only did it in between because we actually tried to do some novel measurements using 5 and 10-minute recordings, but in fact, it became very complicated to do that in dialysis unit because of so much artificial noise. So we found it much easier to do in a hospital setting, in a specific room, a quiet room, and then measure the ECG at that point. But it was always a non-dialysis day. The ionized calcium that we did was also done on a non-dialysis day right after they had their ECG done. That's when we drew the blood. So we also knew that at the time that we did the ECG, we knew that the majority of them had, most of them had normal ionized calcium levels at that time too.
Thanks. So next we have Dr. Samir Bhuvania wanting to ask a question. So I will unmute you, Dr. Bhuvania, and you can go ahead and ask your question.
Could you please tell us the role of statins in dialysis patients?
Oh, yes. And in fact, I apologize because I had a slide. I'm actually going to show you the slide that I had not added. It is complicated to treat patients in statins. And the reason it's complicated is because when you go back to the original trials, and when you go back to the trials, the issue was 4D showed that there was no benefit in a diabetic population on dialysis that were prevalent dialysis patients. So this was the first study in 2005. Aurora then showed within a transplant population that potentially there was some benefit, and Sharp showed within the CKD and dialysis population that there was a benefit, but it was predominantly all from the chronic CKD population. When you look at within the dialysis population, there actually was no evidence of benefit for being on a statin. The difficulty is we have patients that go from CKD to dialysis to transplant. And the question is, how do you manage those patients? Well, the hope is that the time in dialysis will be short. And so if the indication is started before they reach dialysis, I would continue a statin. and I would actually continue it with the goal that you're going to get them to transplant. If they have underlying diabetes, if they have underlying atherosclerosis, if they've already had an MI, they have already shown that they probably still need a statin, and I would keep them on a statin throughout. I think the question is whether a patient shows up and let's say they're a young adult, they're 40, 45 years old, they've had no evidence of heart disease, they're not diabetic. At that point, if you think that you're going to transition them quickly to transplant, then I'm not sure I would necessarily start a statin at that point. But I think for the typical older patient with diabetes and heart disease, I would probably keep them on a statin the whole time, even though it's important to recognize both in 4D as well as in SHARP that there was no significant mortality benefit related to a statin itself. And I think that's because not that statins aren't beneficial for atherosclerosis, but it's because statins don't have an effect on sudden cardiac death. And what the majority of these studies really, all these cardiac events were predominantly sudden cardiac events. Does that make sense, Dr. Bhavani?
So, Dr. Bhavani, does that answer your question?
Yes, yes. Thank you so much.
Thank you. So the next question is from Dr. Shribhushan Raju, and I will unmute you, Dr. Raju. Please go ahead and ask your question. Dr. Raju, can you hear me? We had Dr. Raju's question in the question pane, so maybe he'll come back. But in the meantime, Dr. Nishant Deshpande wants to know how about using antiplatelet agents in dialysis patients? What are the situations in which you would recommend their use?
Oh, so definitely I would use it when you have underlying AFib. And I didn't go into AFib here at all. About 10% of our population is at risk for getting AFib, even while on dialysis, especially those who've got any cardiomyopathy or any atrial dilatation. I think the question is about the type of treatment with AFib is still unclear at the moment on dialysis patients because the bleeding risk is so high. But the overall stroke risk is relatively low. The problem is the mortality and the outcomes related to when you have the stroke are quite poor. So I'm being a little bit on the fence because I think there's a clinical equipoise about which antiplatelet agents should be used and which ones are used best in patients at the moment. There's a recent review that was done, published I think in JASN or CJASN, taking a look at which ones could be used, and I think that there isn't enough data to support one or another yet. So I would use your best clinical judgment based on their underlying cardiovascular risk, diabetes, age, and heart disease, and use that to guide how you're going to treat them for now.
Thanks. Are you able to ask your question now, Dr. Shribhushan?
Not talking. Talking.
Okay. So next I'm going to ask Dr. Narayan Prasad, who wants to ask a question. Dr. Narayan, please go ahead.
Everyone is listening.
Dr. Narayan Prasad, you had a question to ask? Okay, so while Dr. Narayan Prasad prepares his question, can I just ask, what do you think about the role of, you did speak about calcium and magnesium, but calcium and potassium, but do you think magnesium perturbation also might have a role in generation of arrhythmias?
Yeah, surprisingly, magnesium seemed to be the most stable of all the electrolytes, and there was no association, but it might be because there's less fluctuation compared to the calcium and potassium that we have. So I'm not sure it's as relevant, even though I think we probably keep it stable because all of us probably use a stable magnesium bath. And then and patients, as long as they're eating okay, their magnesium stays pretty static. We didn't see any association with QT or prolonged QRS complex.
Right, thanks. So next we have a question from Dr. Ahmad Basir Kaihan from Afghanistan. and he, first of all, he wants to compliment you for your interesting lecture, and then he wants to know why the incidence of cardiovascular deaths among patients on maintenance hemodialysis is more in the first few years compared to other population.
Oh, thank you very much for your compliment, and it's very exciting to see you calling in from Afghanistan. Mortality rates are extremely high in the dialysis population. Within the first few years, I think that it's the majority of patients who are coming to end-stage renal disease tend to be over the age of 65 is the median age within the US or North America. And I think it has a really high burden of inflammation. It has a really high burden of complications, especially if you're diabetic. And the mortality rates are extremely high, I think related to these sudden cardiac events that occur. One of the issues, and the reason I've kept it on this trial slide, is that all these trials that have been done are always on prevalent dialysis patients, where patients have been on dialysis for average 3 years. So you've already got a prevalent population because they've survived, and those who are the sickest have died within the first few years, probably related to underlying diabetes and inflammation and all sorts of other events related to sudden cardiac death. So I think when we study patients who are prevalent, I think we're actually looking at a slightly different dialysis population, and we need to think about those differences that are early deaths versus those that are later deaths. I suspect that calcium and calcification and other types of disease and heart failure become more common in this prevalent population compared to the PACE population, which I think sudden cardiac death was much more common, and probably the most likely reason that most of them died.
Thanks. Next comes a question which I was anticipating from one of our pediatric nephrology colleagues, Dr. Rajiv Sinha, who wants to know how are the cardiovascular risk factors and outcome different in children on dialysis?
Oh, thank you very much, Dr. Sinha. So I didn't show the slides here, but in pediatric patients, they have 100 to 1,000 times greater risk of cardiovascular events compared to the compared to the general pediatric population. In general, they may not have sudden cardiac events as much because they don't have that arrhythmogenic risk because their myocardial substrate is relatively preserved while they're young children. But children who've got chronic kidney disease and adolescents who've got chronic kidney disease, as they age, will start developing more sort of myocardial dysfunction, hypertrophy, diastolic dysfunction, and then ultimately will have probably sudden cardiac death as they get older in their 20s and 30s. So in children under the age of 18, it's extremely important, I think, to maintain their blood pressure control and to minimize as much as you can LVH and minimize any LV stretch that may occur from volume overload to be able to prevent them as they age from getting cardiovascular disease as they get older. So it isn't that they die of sudden cardiac death. It's that you're really putting their myocardium at risk when they're children. And what you want to make sure is that if they survive, that they don't have these problems as they get older on dialysis.
Thanks. Next, we have a question from Dr. Narayan Prasad, who wants to know, what are your views about using aspirin in people on maintenance hemodialysis, especially in diabetics who do not have any clear evidence of coronary artery disease?
Oh, that's a loaded question, right? So you're diabetic, you're on dialysis, you're anticoagulated, and should you get aspirin if you have no atherosclerotic events? In
Yes.
general, what I would say is no, I wouldn't give aspirin unless there was an indication, and depending on how old they are, because the bleeding risks are high. It's really if you're doing it because you're doing it to prevent stroke or you're doing it to prevent coronary disease, it's a much lower risk for the stroke risk. If you're doing it, there's no benefit for mortality unless they've had an MI. So I would say that I think if they were symptomatic from it and had trouble taking it, I wouldn't necessarily push them to have it. And if they had no evidence of atherosclerotic disease and no other potential risk factors other than kidney disease, I would probably not give them the aspirin at that time.
Okay, thanks. Dr. Narayan, Did you want to ask any other question? I think you wanted to ask a question around magnesium and phosphorus, but I can't really make out what exactly it says in the question pane. So if you want to ask, please go ahead and ask. I have unmuted you. I think his microphone is not, he's self-muted, it says here. So here is another question, Dr. Parekh. You have used a 10 to 20 minute ECG in your studies. Do you think that by doing longer term recording, like 48-hour Holter recording, are we likely to get additional information?
Yeah, so I did a pilot study in about 40 patients looking at a Zeo patch where I could get a week of data. Lots of things is going on, and there's unfortunately lots of artifact that you get from dialysis. So it's hard to know. The majority of events occurred within a few hours of dialysis when there were changes. But what's very hard is that it's hard to know how to actually treat any of those things. So it's the bradyarrhythmias we can treat by pacing. We can treat some of the tachyarrhythmias by placing an ICD. But until we actually understand the mechanism of what causes those arrhythmias, it's hard to know. For example, the prolonged QT is easy because in some ways because we can treat the calcium. But the prolonged QRST complex is a little bit harder, other than knowing that you have deranged electrical conduction. So maybe the thing to do is more frequent dialysis as opposed to intermittent dialysis, or do longer dialysis so that you don't cause myocardial stress during those times. So I think what we have to think about is there may not be a specific treatment for each of those arrhythmias that we, even if we get more information, may not necessarily help us. What it'll help us with is maybe thinking about how we should dialyze the patient and how should we maximize their cardiac status as much as possible. So as all of you know, there's studies showing that there's myocardial stress and cognitive function while on the machine, and we never really appreciated that as much because we now recognize there's this myocardial stunning that occurs. And so maybe we need to do a different type of dialysis rather than this 3-hour intermittent 3 times a week, and think about how we actually dialyze patients. And maybe that's the therapy that we should be doing to maximize their life as much as possible.
So I'll ask Dr. Narayan Prasad once again to try, if you have been able to unmute yourself, go ahead and ask your question. No, so we'll go back to the question pane. And so there is a question from Dr. Amit Sharma on the effect of using potassium-free dialysis on the risk of sudden cardiac death.
Oh, so that's an interesting question. I think that severe hypokalemia is also associated with sudden cardiac death in the general population. What was unusual, I thought, was that in fact we had a relatively steady state of what people used for potassium, that it was basically a 2 or a 3, and so we weren't able to show any difference, I think, because there wasn't that much variability between the two. I do think, though, that there's a high risk of rapid changes also. So let's say you came in with a potassium of 7 and you put somebody on a 0. I don't think you should run their entire treatment on a 0. I do think that you should be able to get it down to 5 and then be able to slowly bring it down to where you think you need it. But we haven't been able to show that potassium has been a significant issue. There was a study done in DOPS that took a look overall at potassium and did show that very low potassium baths were associated with the worst outcome. So I don't think that giving a 0 potassium bath is going to improve sudden cardiac death rates.
All right, thanks. So Dr. Narayan Prasad has sent his question, and he wants to know, how frequently do you recommend measurement of magnesium and phosphorus in patients on maintenance hemodialysis?
So typically in the States, we used to do it as part of our, and we do it here as part of our monthly blood draws, that we would be measuring magnesium and phosphorus on a monthly basis. and then making changes based on that. I don't think I would recommend that you doing it more often than that. And the phosphorus itself, just so also from the slide, the Rhine study, Decorn Evolve, again showed no benefit or no difference really between calcium-containing binders versus sevelamer, cinacalcet versus placebo. That in fact phosphorus and PTH doesn't really have a significant effect on all-cause mortality, but even for sudden cardiac death, that there isn't really any association. So I think that's a different mechanism of death. I think that probably causes much more left ventricular hypertrophy, pulse wave changes and stiffness, and leads to heart failure. I don't think it really leads to sudden cardiac death as much.
Right, thanks. So I think an important message that came out from your talk was for people, and you did mention this, that we often use medicines which can have adverse effects, especially in the presence of pre-existing QT prolongation. So we should actually pay that, pay attention to that. And there are a few common medicines like ciprofloxacin, etc., that are used, at least in India, which can have this kind of deleterious effect. So one more question is, do you have any comments on that, Dr. Parekh?
Yeah, I think that when we think about patient safety, we often are thinking about metabolism of the drug related to their kidney disease and being on dialysis. But it wasn't until Jeff Fink had done a patient safety study in the CRIC patients on chronic kidney disease, and also on the patients within a medical system, and showed that, in fact, lots of patients receive QT prolongation medications but never get routine ECGs during that time. And that really struck me as, we're good at prescribing it, we're good at thinking about kidney clearance, but we don't really think about the effect on potential risk for sudden cardiac death or mortality. And that's definitely something I think we should more routinely take a look at and be a little bit more vigilant about looking at their medications. And I was surprised at the list. When I saw the list of medications that they have, it's actually a published list from the American Heart Association, Rhythmogenic Society, and they actually publish a list of all the QT prolongation medications.
Right, thanks. So another question, you did recommend use of ECG for risk stratification. Do you have also any recommendation about the frequency for doing ECGs?
Yeah, no, I mean, I have no data to support it other than my own bias. I think that we do it when they come into the unit. I think that you should do it probably more often, not every month, but maybe a couple times a year. I think if you do it once and you see prolonged QT, I think you need to then think about how are you managing them, and if you make any changes, and probably following up with that, looking at their medications, and then redoing it a few months later to see if it's improved or changed. I think if they have evidence of LVH or any atherosclerotic disease, I think again you should probably do it, a couple times a year, just to monitor and just make sure that you're managing them appropriately. And if you're going to change your dialysis prescription, I think then you should take a look at it and see if anything changed.
Right, thanks. We have, again, a message of appreciation from Dr. Narayan Prasad for your talk and for answering the questions. And also the same from Dr. Vijay Joshi, who finds this talk has to be very useful. So I think we don't have any more questions, which is great because we have come right to the top of the hour. So all that remains for me is to once again thank Dr. Parekh unreservedly on behalf of all the participants for highlighting this important topic and for answering all the questions very, very patiently. Thank you very much.
Oh, thank you very much for inviting me, and I hope you all have a lovely evening. It's snowing in Toronto, so.
Yeah, stay safe there in Toronto.
Okay. All right. Thank you very much.
Thank you. Bye-bye.
Bye-bye.